Hello to everyone. Hello to everyone on behalf of PENTAX Medical, and I welcome all the attendees to this webinar on advanced EUS procedures. We have three national experts connected today. So first of all, thank you to Dr. Avinash, Dr. Sandip Pal, and Dr. Surinder Rana for connecting for this webinar. We will keep the webinar very crisp, very focused on two topics. First is EUS guided pancreatic duct drainage by Dr. Surinder Rana, and the second topic is EUS guided biliary drainage by Dr. Sandip Pal. I will hand it over to Dr. Avinash to introduce the speakers, and then we can proceed with the talks. Over to you, sir.
Yeah, good evening one and all, and thank you PENTAX Medical and Mr. Adar for inviting us for this webinar. It's my pleasure and honor to introduce to you both the speakers. Professor Surinder Rana sir, so we all know like he's a professor at Department of Gastroenterology at prestigious Postgraduate Institute of Medical Education and Research at Chandigarh. And his main research areas has been pancreatic diseases, endoscopic ultrasound, and innovative endoscopy. He has been an avid researcher, so he has published more than 400 research articles in both national and international journals. He has been a recipient of number of national and international awards, orations, including Crystal Award for ASGE, ICMR Award, and Indian National Science Academy Young Scientist Award. He has taken up numerous additional roles, like he has been a part of various task forces of reputed scientific societies. He has been a section editor, pancreatico-biliary of Annals of Gastroenterology. He has been an editor for Journal of Digestive Endoscopy, associate editor of Journal of Postgraduate Medical Education and Research. He has been a member of editorial board of reputed journals like Journal of Gastroenterology and Hepatology, Endoscopic Ultrasound, Indian Journal of Gastroenterology, and World Journal of GI Endoscopy. So we welcome you, sir, for this webinar. Second speaker was my colleague at CMC Vellore, so Dr. Sandip Pal. So he is currently working as a consultant intervention gastroenterologist and hepatologist at Narayana Hospital, Kolkata since 2014. Before joining Narayana Hospital, he worked as assistant professor in the Department of Gastroenterology. He's been a recipient of Young Investigator Award at ISG Indian Society of Gastroenterology meeting in 2011. He's been a lifetime member for Indian Society of Gastroenterology, SGI India, West Bengal chapter of ISG, and a trainee member of American Society of Gastrointestinal Endoscopy. He has got many publications in both national and international journals. So we welcome you, Dr. Sandip, for this webinar. So we are going to have an exciting topics on therapeutic EUS. So first of all, we invite Dr. Professor Surinder Rana sir for taking our session on EUS pancreatic duct drainage. And following that, Dr. Sandip Pal will talk on EUS biliary duct drainage. Over to you, sir.
Good afternoon, everyone. Thank you, Avinash, for the kind introduction. And good afternoon, Sandeep, also. And at the outset, I would like to thank PENTAX for taking this educational initiative of doing these webinars in these tough times, when the education is already compromised because of the pandemic. So I think it's a good initiative to do these webinars for especially postgraduates. And I congratulate PENTAX for taking this initiative. So is my screen visible?
Yes, sir.
Okay. So as already told, I'm going to talk about EUS guided pancreatic duct drainage. So if we look at pancreatitis, it has been an enigmatic disease, lurking in its retroperitoneal layer, enshrouded in a miasma of complex physiology, ill understood pathology, difficult surgery, and dubious therapy. The pancreas has for centuries challenged the finest scientific minds. And if we look at the management of pancreatitis and its complications, the traditional management over years has been conservative and surgical therapy. And we all have seen, witnessed, and know that surgery is associated with high morbidity and mortality. Occasionally, such patients have been now treated with percutaneous radiological procedures, but it is the advent of endoscopic therapy which opened an era of effective, minimally invasive, and safe treatment of various complications of pancreatitis. And this has reduced the morbidity and mortality which was associated with surgical therapy. So if you look at the endotherapy, or precisely the ERCP, which started in 1970s, initially it was to locate the ampulla, attempt a CPT or a pancreatic duct cannulation, and most of the time initial ERCPs were diagnostic ERCP. Subsequently, with improvement in the technique and the accessories, came the biliary sphincterotomy, the stone extraction, placement of plastic stents for malignant strictures, and then subsequently there was a widespread acceptance of ERCP. During the same period came the pancreatic endotherapy, which was a transpapillary pancreatic duct drainage. Along with that, there were refinement of accessories, and then we started recognizing the complications of ERCP. And now in this current decade of ERCP, now we have a development of EUS MRCP. We started developing self-expanding metallic stents for biliary and pancreatic applications. There was more stress on safer ERCP, evidence-based ERCP, and now we had a plethora of randomized and prospective studies on ERCP. Along with these things, we started realizing the limitations of endotherapy for pancreatic diseases. We all know about an endoscopic transmural drainage of pancreatic fluid collections, and although effective, we knew that there were serious complications associated with a transmural drainage, which were bleeding and perforation, and then we were unable to drain the non-bulging collections, the collections which didn't have a bulge on endoscopy. Similarly, ERCP, transpapillary drainage, pancreatic sphincterotomy, quite effective for various pancreatic complications like communicating pseudocysts, refractory strictures which can be dilated and multiple stents can be placed. But then as we started using ERCP, we recognized there were certain situations where we could not succeed. For example, if we are unable to cannulate the pancreatic duct selectively, failure to negotiate the tight strictures, and then disconnected pancreatic duct, which is now a quite common complication with necrotizing pancreatitis, and patients who had a surgically altered anatomy. In those patients, you were unable to reach the pancreatic duct and do the endoscopic interventions via the ERCP route. So along with this, EUS emerged, and we had a therapeutic EUS coming up, and hence a new kid probably emerged in the interventions of pancreatitis and its complications. And now we have quite a number of EUS guided pancreatic interventions. Almost for last 2 decades, EUS guided drainage of pancreatic fluid collections have evolved, and now a lot of centers are doing EUS guided drainage of pseudocyst and walled-off necrosis, and now it's almost the first line therapy for central necrosis in patients with acute pancreatitis. Along with that, EUS guided pancreatic duct drainage, the topic of discussion today, is also coming up, which is used for pain relief, and also in patients who have a refractory external pancreatic fistula with a disconnected pancreatic duct syndrome, where you can't cannulate and selectively place a stent deep into the pancreatic duct. Here, EUS guided pancreatic duct drainage comes to the rescue. And then other interventions are EUS guided pancreatic tumor ablations, which are again coming up in a big way in last few years. So the topic of discussion today is EUS guided pancreatic duct drainage. If you look at the techniques of EUS guided pancreatic duct drainage, they are almost similar to the ones which are used for EUS guided biliary interventions, which Dr. Sandip is going to talk about subsequently. However, there are few minor variations in pancreatic duct drainage as compared to a biliary duct drainage, which I am going to discuss in little detail in subsequent slides. However, we have to understand that EUS guided pancreatic duct interventions are more difficult than biliary interventions, because first, we are puncturing an organ pancreas, which is quite firm in comparison to thin duodenal wall and a bile duct wall. There is a tendency for the guide wire to slip into side branches because the pancreatic duct has got a narrower diameter as compared to the bile duct. And the orientation of the pancreatic duct to the echoendoscope is less favorable in pancreatic duct interventions as compared to biliary interventions. And finally, there is lack of dedicated stents for PD interventions. Because of these 4 reasons, EUS guided pancreatic duct interventions are more difficult than biliary, and you will many times encounter failure as compared to biliary interventions. So if you talk about EUS guided pancreatic duct drainage, I personally feel it's the most challenging interventional EUS procedure. Firstly, because the target, which is the dilated pancreatic duct, is relatively small. and one has to reach that pancreatic duct after puncturing a fibrotic pancreatic parenchyma that is very, very difficult to puncture with standard needles. I am sure many of us who would have gone to surgical OT and seen a patient of chronic pancreatitis being operated would have realized how stiff and firm is a fibrotic pancreas because of chronic pancreatitis, and it becomes much, much more difficult in patients who have got a chronic calcific pancreatitis. Secondly, the stability of an echoendoscope in stomach is relatively low. The stomach is quite big distended organ, so the stability is low, and many times the scope will fall back and you will lose the tract, and it does not allow the application of force with much strength and efficacy as you do in a biliary drainage. Then the manipulation of the guide wire through the needle is difficult. First, because the diameter of the duct is very small, and then because of this reason, there is the risk of peeling of the guide wire or looping of the guide wire into the retroperitoneal cavity, and you will create a false track. And then finally, and most important thing which one has to remember while doing an EUS guided pancreatic duct drainage is pancreas, even in a setting of chronic pancreatitis, it remains a very fragile organ. Many times we start believing that if the patient has got a chronic pancreatitis, there is very little chance the patient may develop pancreatitis. But if you are doing an EUS guided pancreatic duct drainage, you are very aggressive and you put a lot of trauma onto the pancreas. Even in this stage of chronic pancreatitis, you can have a severe pancreatitis, which can lead on to severe adverse events. So that's why, because of these reasons, I believe that EUS guided pancreatic duct drainage is the most challenging interventional EUS procedure. Fortunately for us, the need for EUS guided pancreatic duct drainage is very rare in clinical practice. So you have to really justify the reason for doing an EUS guided pancreatic duct drainage in a particular patient before you go on to this relatively high risk procedure. So let's look at the indications for EUS guided pancreatic duct drainage. The indications for EUS guided pancreatic duct drainage are symptomatic obstruction of the main pancreatic duct after you have a failed ERCP and the patient is high surgical risk. So these are the two important criteria. First, an ERCP should have been attempted by an expert and he should fail. And secondly, the surgery should not be an option because the patient is a high risk for surgery. So if these three conditions are met, then it's an indication for EUS guided pancreatic duct drainage. And then if you have a symptomatic obstruction of main pancreatic duct in patients who have an inaccessible papilla because of post-surgical anatomy, that could be gastrectomy, Roux-en-Y anastomosis, or a post-Whipple's procedure. And the last indication would be a symptomatic patient who is having a disconnected pancreatic duct syndrome and is not a fit candidate for surgery. So one of the most important considerations before embarking upon an EUS guided pancreatic duct drainage is the surgical candidacy of the patient. So if the patient is fit for surgery, then this procedure should not be offered. Patient should be offered a surgery, and this should be reserved for suboptimal surgical candidates or patients who are desiring a minimally invasive approach despite counseling and informing them about the risks of EUS guided pancreatic duct drainage. So what we follow is a step-up approach of a patients who have failed ERCP and are symptomatic because of pancreatic duct obstruction. First is consideration of surgical candidacy. If patient is not fit for surgery, then first one should attempt a rendezvous procedure, that is a rendezvous assisted ERCP. And if we are not able to pass the guide wire across the papilla, then only one should resort to an anterograde EUS guided pancreatic duct drainage, which involves puncture and dilatation of the transmural tract, followed by placement of a stent to create an alternative drainage route. What are the contraindications for EUS guided pancreatic duct drainage? Severe thrombocytopenia, severe coagulopathy, inability to localize the main pancreatic duct using an endoscopic ultrasound, many times because of the abnormal location of pancreas, you are unable to localize the main pancreatic duct from the stomach or duodenum. In those situations, EUS guided pancreatic duct drainage cannot be done. If there are intervening structures in the transmural tract, that is vasculatures, which you cannot avoid while puncturing the duct, then this drainage should not be done. And finally, patients who have got multiple main pancreatic duct strictures, there is no point doing an EUS guided pancreatic duct drainage because even in the best of hands, all these strictures cannot be negotiated and the outcome of this procedure is very, very poor. Now coming to the technique of EUS guided pancreatic duct drainage, there are two access routes for identifying and puncturing the main pancreatic duct. Either it can be transgastric or through the stomach, and it can be transduodenal or transantral. The puncture site in stomach is usually in the upper portion of the stomach. If sometimes you are unable to puncture the pancreatic duct from stomach because of poor localization, then we follow this maneuver. This is quite effective. You should take the scope into the second part of duodenum and then pull back. So once you pull back and get into the stomach, you will find a main pancreatic duct from the lower or middle portion of the stomach, and this is one of the most easier sites to puncture and place a stent in case you are planning an antegrade EUS guided pancreatic duct drainage. Now, which needle should be used to puncture the main pancreatic duct if you are planning a EUS guided duct drainage? The pancreatic duct can be accessed with a 22 or a 19 gauge needle. The advantage of a 22 gauge needle is that it is easy to puncture even in a fibrotic pancreas, or if the pancreatic duct is stiff, or if it is less than 5 millimeter. So in these situations, 22 gauge needle would be preferred. However, the disadvantage of 22 gauge needle is that it can only accommodate a 0.018 or a 0.021 inch guide wire. These two guide wires have problem with fluoroscopy visibility, and they have an insufficient stiffness that can subsequently hamper a placement of stent. On the other hand, a 19 gauge needle, which can accommodate a 0.025 or a 0.035 inch guide wire, is the optimal choice to access the main pancreatic duct in doing an EUS guided pancreatic drainage, unless and until the pancreatic parenchyma is highly fibrotic, where one has to use a 22 gauge needle with a thinner guide wires. Now, which guide wire is to be used? There are a number of guide wires which are commercially available. For drainage procedures, because of stiffness and better fluoroscopy visibility, we use a 0.025 or a 0.035 inch guide wire. At our center, we prefer a 0.025 inch stiff guide wire with an angled tip. It is soft, has got a highly flexible tip with an outstanding radio opacity. There is a clear endoscopy visibility. There is sufficient stiffness at the guide wire shaft, and it has got an ability for easy therapeutic instrument exchanges if required, especially in rendezvous procedures, and there is less kinking. The only thing which one has to remember while doing this procedure is that there can be a guide wire shearing at the needle tip, especially if there is an aggressive manipulation. So your assistant should be an expert in manipulating the guide wire in a narrow pancreatic duct from the sharp needle tip. And one should use a half strength contrast medium because it allows an easier injection through the 19 gauge needle. Now, which drainage route should be used, either transgastric or transduodenal? I think it depends upon the anatomical feasibility, and one should comprehensively judge the puncture angle to the main pancreatic duct. One should look at the ergonomic feasibility and the way one can easily push the stent. If there are blood vessels around, that track should be avoided, and also the distance from the stenosis. If the distance is too long from the stenosis, sometimes it becomes difficult to negotiate the guide wire across the stricture. The transduodenal approach has an advantage that there is a long position of the scope, which allows a better visualization of the main pancreatic duct for the puncture as compared to transgastric approach. So there is intraoperative stability of the scope and ease of pushing the stent, because it is almost like an ERCP, you are pushing a stent into the pancreatic duct. However, the only problem is the gastroduodenal artery runs quite close to the site of punctures. So one has to be very, very careful and avoid the gastroduodenal artery. And many times we are using a cystotome to dilate the tract. And we all know that these cautery devices, especially the coaxial ones, have a burnout effect at distant areas. So many times the gastroduodenal artery, which is about 0.5 to 1 centimeter away from the tract puncture site, can have a delayed thermal bleed. So one has to be very, very careful about the gastroduodenal artery. So if you look at the evidence, there is no difference in technical and clinical perspectives by either route. So one should attempt puncturing from the site where you have better conditions to perform the procedure. Otherwise, there is no difference in the outcome between the two routes. Finally, one of the most critical steps of pancreatic duct drainage is the dilatation of the fistula. So here you have to dilate the gastric or a duodenal wall, the pancreatic parenchyma, and the main pancreatic duct. So it's a quite amount of structure which has to be dilated. So first and foremost, the guide wire should be advanced deep enough for the rigid part to reach inside the main pancreatic duct. You should ensure that the floppy part of the guide wire should not be in the tract, otherwise the guide wire will slip out. One should efficiently apply the force in the same direction as the puncture. So the important point is, the point from where you have made the puncture, you should not change the scope position. So the scope position should be the same at the time of dilatation as it was the time of puncture on fluoroscopic imaging. So what we do is we puncture the pancreatic duct, click a photograph of that fluoroscopic image and use it as a reference. And when we are dilating it with the cystotome or any other accessory, then we use the same as a reference. Now for dilatation, we have non-electrocautery devices like mechanical and balloon dilators, or we have electrocautery devices like non-coaxial type, which are needle knife, and a coaxial type, which is a cystotome. As I've already talked about, the electrocautery devices have a problem of burn effects, sometimes leading on to severe adverse events like pancreatitis, pancreatic juice leakage, bleeding, and perforation. And many authors from Japan actually are developing and have developed many novel non-electrocautery devices because they believe that the cautery devices lead on to more complications. However, if you look at literature, right now there is no study to suggest that cautery devices are associated with more complications as compared to non-electrocautery devices. Finally, which stents to be used? One can use 7 and 5 French plastic stents. We also have an 8 millimeter self-expandable metal stent, and sometimes we can also place a 5 French or a 7 French nasopancreatic duct drain, and which can be subsequently exchanged to a 7 French plastic stent. It all depends upon preferences, but in the first session, one should not be aggressive. One should try to place a 5 French or a 7 French stent, and after 1 to 3 months later, exchange these transmural stents with larger stents. So initial session should be just that much dilatation, which would allow a smaller caliber stent like a 5 French or a 7 French stent to be placed. So the factors to be evaluated while we are doing an EUS guided pancreatic duct drainage is, what is the indication for PD access? If the indication is a stent placement, then one should use a 19 gauge needle. If the intention is a pancreatography or a rendezvous procedure, one should use a 22 gauge needle. Or in case the pancreas is very, very stiff and 19 gauge needle is not able to puncture, then for a stent placement, one can use a 22 gauge needle, but then one will have to use a stiffer 0.018 or 0.021 inch guide wire. Then one has to assess the degree of pancreatic duct dilatation. 19 gauge needles are used only if the dilatation is more than 5 mm. Less than 5 mm dilatations, one has to use a 22 gauge needle. And if there is a fibrotic stiff pancreas, then one will have to resort to use a 22 gauge needle, as 19 gauge needle will be very, very difficult to use. Now, just to show you some examples, this is a patient with a chronic pancreatitis with a large stone. ERCP failed because the guide wire could not be negotiated across this large stone. So a rendezvous procedure was attempted. So you can see that the pancreatic duct is punctured from the tail end and the guide wire is being pushed, and subsequently the guide wire came out through the minor papilla, and then we exchanged it with an ERCP scope and a transpapillary stent was placed into the dorsal duct. Now, the EUS guided transmural pancreatic duct drainage can be of many types. It can be anterogate transpapillary, that means you puncture the pancreatic duct from the stomach and take the stent outside the papilla. It could be anterogate transgastric, that means you puncture from the stomach and leave the stent in the pancreatic duct. It can be anterogate transenteric, that means from the duodenum you come into the pancreatic duct. It could be retrograde transpapillary, that means you puncture the pancreatic duct on EUS near the papilla and place the stent like a transpapillary. It could be a retrograde transgastric, that is you're going towards the tail end from the stomach, and it can be retrograde transenteric, that is from the duodenum you're getting into the pancreatic duct and going into the tail. So these all modifications of transmural duct drainage are available, and depending upon the anatomical situation in an individual patient, these procedures can be adopted. Now, this is a patient with a pancreatic pleural effusion. ERCP failed because of inability to deep cannulate the pancreatic duct. So we resorted to EUS guided pancreatic duct drainage. You can see that the pancreatic duct has been punctured. There is a pigtail in the pleural cavity. There is a complete cutoff because of the tight stricture stone complex. The tract is dilated with the wire in place, and then you place a transmural stent. So this is a pigtail stent which has been placed, one end in the duct and one end in the stomach. And then you can see on a follow-up CT, the pancreatic pleural effusion has resolved. Similarly, patient with disconnected pancreatic duct syndrome with chronic pain, you puncture the pancreatic duct from the stomach, obtain a pancreatogram, and then you place a stent, which is a pancreaticogastrostomy stent. The same thing on a CT scan, you can see that this is a single pigtail stent where the distal end is at the stricture stone complex. Coming on to the literature, the success rates are not as good as biliary drainage, but many centers have reported success rate more than 90%. The clinical success is little less, ranging from 60 to 80%. The only thing to remember is the complications, which are as high as 35%. This is our experience of transmural drainage published recently. We have used in 12 patients, technically successful in all, but the problem is complications: self-limiting bleed in 1, guide wire slipped out in 1, and abdominal pain in 3. And then on follow-up, external stent migration was seen in almost 5 out of 12 patients. So still, because of lack of dedicated stents, the long-term efficacy of this procedure is still unclear. Finally, about external pancreatic fistula. External pancreatic fistula can be capsulated. Capsulated means that there is a small pancreatic fluid collection which can be punctured under an EUS guidance. Like in this case, you place a transmural stent and this will lead on to healing of external fistula. But the problem is non-capsulated external pancreatic fistula. There are various modifications which we have described. One is that you clamp the pigtail catheter and sometimes a small fluid collection will form. You puncture that and place a stent and that will heal. And if that does not happen, then another modification is that you inject saline and create an artificial fluid collection, as in this case, puncture it under EUS guidance and place a transmural stent and the fistula will heal. And sometimes on EUS, you can see the transmural tract, as you see in this case, that the pigtail catheter is very, very close to the site of puncture. So you directly puncture the fistula tract, take the guide wire in and place a transmural stent. And if all this does not suffice and you are not able to do it, then one can resort to an EUS guided pancreatic duct drainage, as done in this case. But the only problem is in external pancreatic fistula, the ducts are not dilated. So one has to resort to use a 22 gauge needle with a 0.021, 0.018 or 0.021 guide wire. Finally, another interesting use of EUS guided pancreatic duct intervention is to remove proximally migrated pancreatic stents. Like in this case, we failed to remove the stent transpapillary. So what we did is puncture the stent through the stomach using an EUS scope and then push the sheath in. So that led on to pushing of the stent downstream and we could retrieve the stent from the papilla. So finally, to conclude, what we have learned is that EUS guided pancreatic duct drainage can be considered after failed ERCP or in patients with inaccessible papilla because of surgical anatomy or patients who have a disconnected pancreatic duct syndrome. However, care must be taken to avoid using these latest treatment options as a justification for an incomplete attempt at ERCP. So these procedures should be done by experienced endoscopists who have a sufficient experience in ERCP and then only they fail. We have to remember that it's a technically challenging procedure with failure rate of around 10%, even in most experienced hands, and rate of moderate to severe adverse events above 10%. So above 10% adverse events are actually quite high. So one has to be very, very careful before contemplating these procedures. So we need to understand that new and novel techniques often bring excitement and enthusiasm, but they should not replace a clear clinical sound judgment. So to conclude, the human dilemma is not whether to do right or wrong, but rather to do right when it matters the most and wrong when it matters the least. And I think it is very, very true for EUS guided pancreatic duct drainage. You should choose it carefully in the patient in whom you are going to do good more than the bad. Thank you so much for your patience.
Thank you, sir. Thank you, Rana, sir. As usual, it was wonderful and exciting. So we'll take question and answers after the second talk, sir. So now we invite Dr. Sandip Pal to talk on EUS guided biliary duct drainage. Dr. Sandip, please.
Yeah. Good evening, everyone. Am I audible?
Yeah.
Yeah. My screen is visible?
Yes. Please go ahead.
Okay. I'll just minimize this. So good evening, everyone. Good evening, Avinash, Rana sir, and the PENTAX officials. So the topic I am going to discuss today is EUS guided biliary drainage. So as we know, so often we need biliary drainage for conditions like biliary obstruction, which are usually maybe malignant and benign sometimes. So the biliary drainage options are the most common option that all of us do is ERCP. And if we fail in ERCP, then another option is PTBD done by the interventional radiologist. And the third option is EUS guided biliary drainage. Now, EUS guided biliary drainage has emerged as a technique for gaining biliary access when when ERCP fails. So ERCP fails in 5 to 10% of cases due to inaccessible papilla or inability to cannulate the papilla. So what are the reasons for ERCP failure? These include altered anatomy, ampullary distortion, periampullary diverticulum, gastric outlet obstruction, or if there are duodenal stains for gastric outlet obstruction. So conventionally, PTBD has been done when ERCP fails, but PTBD is associated with high adverse events, and it in the tune of, it's mentioned in the literature, about 33% complications can occur with PTBD, and the various complications like bleeding, bile leak, dislocation of the external catheter, recurrent infection, or acute cholangitis. So, and also the catheter related morbidity from the external drainage, as well as it may worsen the patient's quality of life. And EUS guided biliary drainage has several advantages, like first, it is minimally invasive and can be performed directly as the procedure when ERCP fails in the same session by the same proceduralist. And second, drainage of both intrahepatic and extrahepatic bile ducts can be achieved. Third, it is minimally invasive with minimal or no procedural and fourth, as opposed to PTBD, there is no external drain that can limit the patient's daily activities. So the current indications for EUS guided biliary drainage are if the for accessible papilla, if there is ampullary pathology or periampullary diverticulum, ampullary neoplastic infiltration, and for non-accessible papilla, if there is peptic GI stenosis, malignant GI structures, gastrointestinal bariatric bypass, Roux-en-Y gastric bypass, or Bilrod to gastroenterostomy. So EUS guided biliary drainage, it can be extrahepatic or intrahepatic. Extrahepatic like choledochoduodenostomy or rendezvous procedure, and intrahepatic, it can be rendezvous or it can be a placement of antegrade stent or it can be a hepatogastroscopy. So these are the three so these are the three procedures that we usually do. One is my screen has disappeared.
No, we can see Sandip.
No, but this has come in between my slide. I cannot see my slide. There is no option to minimize this.
Just move to the next by pressing the next button, sir.
Yeah, this okay. Sorry. So it can be intrahepatic biliary drainage or extrahepatic biliary drainage. So intrahepatic biliary drainage, usually it can be hepatogastroscopy, where the puncture site is usually from the stomach. Here the advantage is the scope stability is good. This is a stable scope position. Needle maneuverability is also easy. Diameter of the bile duct is but small, and the needle direction should be towards the ampulla, and distance to ampulla is long. Whereas in extrahepatic biliary drainage, that is choledochoduodenostomy, we do it usually from D1. Here the scope position is also stable, but the needle maneuverability can be difficult. But the diameter of the bile duct is large because it's often obstructed in the distal end, so the bile duct is dilated. And the needle direction should be towards the hilum, and the distance to papilla is short. And this is one more position by reducing the stope we can attempt, but I have not done this. But this is another possibility where it can be punctured. The bile duct can be punctured from D2. But the scope stability is an unstable position, but all other things are better, like the needle maneuverability and diameter of the bile duct is better, and the needle direction here is towards the ampulla. So this is choledochoduodenostomy. The indications are already I have discussed this. The indications of choledochoduodenostomy: if there is a malignant distal common bile duct obstruction due to pancreatic cancer, distal cholangiocarcinoma, or periampullary cancer. So these are the steps. So in comparison to pancreatic duct puncture, as discussed by Rana sir, this is not that difficult to puncture, because it's like whenever the bile duct is obstructed distally, the bile duct is very adequately distended, as you can see in this first picture. So you can puncture it with the needle, then do a cholangiogram and put a guide wire, and we can dilate the tract with a 6 French cystotome, and if required after 6 French cystotome we can use a 4 hurricane balloon, and after the dilatation of the tract you can put a stent. Usually covered stent is put in colorectal because to avoid biliary leak, but sometimes sometimes you can put plastic stents also, but the problem with plastic stent is there is high chances of bile leak. So this is one of my patients where we have done this duodenostomy. So this patient, as you can see, the cannulation failed because of deformed papilla. When we tried the pre-cut, after pre-cut also the papilla could not be accessed. The bile duct cannulation was not possible. Sorry. I think the video is long. I cannot fast forward it here. I'll skip this video. I think we all have seen this video, this procedure. We are all aware of this procedure, so it's not very difficult. So as I have shown in the picture. So next, coming to hepaticogastrostomy, the indications of hepaticogastrostomy is it's a difficult or failed ERCP in patients with hilar stricture. For example, if the patient has got CA, gallbladder or cholangitis carcinoma or distal biliary stricture, and if the bile duct cannot be accessed from D1, if there is a D1 stricture, or if there is a placement of duodenal metal stent, or if there is a gastric outlet obstruction, then the biliary drainage can be attempted from the stomach. So these are the steps of hepaticogastrostomy. So for this, to do a good hepaticogastrostomy, we should be aware of the anatomy of the liver by EUS. Usually there are two segments, segment 2 and segment 3, which is divided by the left hepatic vein. So we should always try to puncture the segment 3 duct, because that is well accessible from the stomach. Yes, sometimes we need, sometimes when segment 3 ducts are not easily accessible, we can also access the segment 2 duct, but we should always avoid to puncture it from the esophagus, because sometimes if we puncture it from the esophagus, the patient might develop mediastinitis and all. So should, for all practical purposes, puncture of the bile duct from esophagus should be avoided, and always we should try to puncture a segment 3 duct. So here in this picture, the first picture, this one is the segment 3 duct. So this is punctured with the 19 gauge needle. A cholangiogram is done, and after cholangiogram, again the tract is dilated. The tract is punctured with a 6 French cystotome. We can dilate it with a 4 hurricane balloon, and thereafter the stent can be deployed. So usually the geobore stent is deployed in this procedure. So usually, initially we used to put 8 centimeter stents bound, but now the trend is to put longer stents, so that more and more stent is there in the stomach. More and more part of the stent is there in the stomach, which prevents migration of the stomach in the peritoneum, which should prevent in the migration in the peritoneal cavity. So this is the final position. I have a video for this. I think I will be able to show this video because this is a short video. Sorry. Yeah. So this is a patient who had gastric outlet obstruction due to I think he had a periampullary malignancy which had obstructed the duodenum also. So you put a stent in the duodenum, metallic stent, and for this biliary drainage, you can see here the bile ducts are massively dilated, and we will puncture a segment 3 duct. So when my needle comes, and it's not that difficult to puncture it because it's very hugely massively dilated intrahepatic biliary radicals. So you should always, for this procedure, we use a 19 gauge needle and 19 gauge needle to puncture the intrahepatic biliary radicle. So here I am inside the duct. As you can see here, the duct has been punctured. After that, we do a cholangiogram. As you can see, the biliary radicals are hugely dilated. And after that, we try to manipulate the guide wire so that get a stable position. And as Rana sir was telling, the same same in this, like the guide wire, the floppy part of the guide wire should be well inside the system, because that is relatively unstable part. So once we put the guide wire, the tract is dilated with a hurricane balloon, or you can use other dilators also. I have used Surendra's dilator, or with Surendra dilator like 7 French dilators. And after, once the tract is dilated, you can deploy the stent. The most important point in these procedures is that everything should be done in the EUS view. So if we try to see the endoscopic view, then the axial force does not come and it becomes difficult to deploy the stent. So the force should always, the stent should be always be deployed under the endoscopic view, under the EUS view. So here the stent has been deployed at a good biliary drainage. Good, we could see good bile drainage. And this is a relatively long stent I have put in this patient, almost 10 centimeter geobore stent. And nowadays the geobore stents which are available are 25% and 75%. 25% uncovered, the part which is inside the liver, and the rest is covered. So the third method of biliary drainage is EUS rendezvous procedure. So this is sometimes when the ERCP is not possible due to inaccessible papilla, we can puncture the bile duct. Either we can do it from transgastric route or from the transduodenal route, and once the guide wire comes out through the papilla, you can catch hold of the guide wire and take it out through your scope and cannulate it. Or sometimes you need not take out the guide wire also, alongside the guide wire you can cannulate the papilla. So this is a slide which shows the choice of stents in EUS biliary drainage. So in rendezvous procedure, we can use a plastic stent, uncovered metal stent, or covered metal stent. Lamps or tubular stents are not used. For transluminal choledochoduodenostomy, if the CBD diameter is less than 15 millimeter, plastic stents always a question mark, but because sometimes when cost is a matter, we have put plastic stents in choledochoduodenostomy also, but there is high chances of bile leak. Uncovered metal should not be put, only covered metal stent should be put. And if the diameter of the CVD is more than 15 mm, so then we can try to put lamps. Covered metal we can always put, but therein lamps can also be placed. For transluminal hepaticogastrostomy, plastic stents are there. Plastic stents, those plastic stents are not available here in India. I think I don't know if it is available now, but there are some plastic stents which can be placed for transluminal hepaticogastrostomy, and tubular stents are usually put, those geobore stents. And for antegrade, the choice of stents is uncovered metal stent. So these are the various, now coming to the studies. These are the two studies where Park et al. And Tyberg et al. These are both prospective studies where they have shown the technical success rate of these US guided biliary drainage about more than 90%, 91% and 96%, with complication rates of around 10 to 11%. So these are the various studies which have showed the success rates of biliary drainage, and all the studies have shown that technical success rates is more than 90% in experienced hands. So the advantages of ERCP is it's widely available, relatively low complication rate, but the disadvantage is not feasible in case of inaccessible papilla. For PTVD, it is an available rescue therapy for ERCP failure, but it's a high complication rate, and external catheter is contraindicated if there is ascites. And for the EUS, different procedures are available, but the disadvantage is it's not widely available, and a learning curve is there. So learning curve is there, and the algorithm is not yet standardized. Now, if we compare intrahepatic versus extrahepatic approach, a large retrospective study including 245 patients revealed a similar success rate between intrahepatic and extrahepatic approach. Dr. Vinayadhir et al. Assessed the intrahepatic and extrahepatic approach for EUS rendezvous for distal common bile duct obstruction, and they confirmed that the success rates were equal. And a multi-center study looking at the efficacy and safety of USBD concluded that the extrahepatic approach was significantly associated with decreased procedure time, length of hospital stay, and the risk of moderate adverse events. So in clear words, the choledicoduodenostomy is better than hepaticogastrostomy in terms of complications and in terms of success rates. Similarly, hepaticogastrostomy versus choledicoduodenostomy, the same thing. These are other studies which also show that that the choledicoduodenostomy might be easier if it is possible to do in a biliary obstruction patient than hepaticogastrostomy. The only problem is the complications might be a little bit higher in choledicoduodenostomy in terms of stent blockage and cholangitis, because food materials, this all might enter from the duodenum to the via the stent to the biliary system. Now coming to this slide, US biliary drainage versus PTBD. There are studies like Artifan et al. Compared the efficacy and safety of choledicoduodenostomy versus PTBD. It's a randomized study including 25 patients, and they concluded that both the methods had technical success, clinical success, and adverse event profile were equal. But there are other studies like the study by Giovanni et al. Showed in 41 patients that the complication rates were more in patients who underwent PTBD. And actually in that study, they had to stop recruitment of patients in the PTBD group because of high complication rates. So these are the various studies which have compared USBD to PTBD, where the success rates, technical success rate, clinical success rate is equivalent between both the PTBD and US guided biliary drainage, but in all the studies have reported that the adverse events were more in PTBD group in comparison to the US biliary drainage group. So this is a analysis of three meta-analysis and systemic review of 3 RCTs and 6 retrospective studies, which showed that technical success rates were equivalent and clinical success was better with USBD. Adverse events were less, re-intervention rates were lower, duration of hospital stay was same, and the cost is less. So my experience in my hospital actually depends on the person who is doing the procedure. If the radiologist is very experienced, I have not seen such complications, so much high complications in PTBD as is mentioned in literature, our literature. So US guided biliary drainage versus pre-cut sphincterotomy. So this is one area where a small prospective clinical study including 18% showed that it's as effective as first-line biliary drainage therapy with success rates of 94%. This already we have discussed. So it's known that if the cannulation of the papilla is difficult, then there is high chances of pancreatitis. So difficult biliary access leads to increased manipulation, additional procedure time, and multiple attempts, making patients prone to adverse events, most importantly post-ERCP pancreatitis. So in those cases where it is very if the cannulation is difficult, so rather than attempting again and again to cannulate the papilla or before using pre-cut sphincterotomy, if we try US guided biliary drainage, the studies have shown that it might be better than attempting pre-cut sphincterotomy. So this was a study by where it concluded that US guided biliary drainage can be used as an alternative to pre-cut sphincterotomy, and a recent retrospective study showed that the ERCP failure rate decreases when USBD is available, and the success of USBD was significantly higher than for pre-cut, which supports the role of USBD as an alternative to pre-cut after failed cannulation. So these are the two studies by Dheer et al. And Lee et al. Which showed that the technical success rate when compared to pre-cut papillotomy is better with USBD when in comparison to pre-cut papillotomy. Even the p-values were significant. So again, the one meta-analysis has systemic review for US guided biliary drainage. This was a huge study, like almost 23 studies on 1500 patients. And it compared around 1500 procedures, which showed that the technical success rate was around more than 90%, 91.5%. And the clinical success was 87%, though there was a great degree of heterogeneity in this systematic review. and the re-intervention rate was 6.5%, and the adverse events were 17.9%. The subgroup analysis of this systematic review showed that the bile leak was in 4%, stent migration in around 4%, and infection was around also in 4%. Now, this is a very important question. So, should we attempt US guided biliary drainage in benign strictures? So till now I have not done. I am not sure if other panelists, if they have attempted US guided biliary drainage in benign diseases, but this is a study in multi-center non-randomized study of 240 patients, where 44 patients had benign disease, and this study showed that the higher success rate of US guided biliary drainage was in malignant disease when compared to benign disease. The reason is because in malignant disease, the bile duct is more dilated, and the bile duct might be fixed to the duodenum or the stomach, thereby it makes the access easier. And another explanation is in benign disease, we might use a plastic stent, whereas in malignant disease, we will be using a metal stent. So now coming to the last portion of my talk, the adverse events related to US biliary drainage, it ranges from 3.4 to 38%, in the average of around 17%. I have already discussed this, but the various complications which can occur is bile leak, bleeding, cholangitis, sepsis, and stent migration. More complications, actually the initial studies showed more complications than the later studies. The studies which are being reported now, they show less complications, because now almost for all practical purposes for US biliary drainage, plastic stents are not being used. So the complication rates in the recent analysis or the recent studies are less. So it showed that the plastic stents was associated with higher rates of cholangitis, and also that this is a well-known fact that meta-analysis also showed that the adverse events were lower in metal stents in comparison to plastic stents. And also a cohort study from tertiary care center showed that ESBD was of patients with a native fibula undergoing therapeutic biliary ERCP. Lower technical and success rates and higher complication rates have been reported during the first 20 US BD procedures. So there is a learning curve. So it investigated, this O et al. Investigated the learning curve for US hepaticogastroscopy in a prospective study involving 129 patients, and they demonstrated that the procedure time and the adverse events were shorter after 24 cases, and it stabilized at 33 cases of US HGS. So after at an average of 30 cases, one has to do to have lower complication rates and higher success rates. So a multi-institutional survey among experts revealed that US biliary drainage could replace PTBD after ERCP failure. Rendezvous stenting technique should be the first choice. Most endoscopists recommend the use of SEMS for US biliary drainage, and 8 to 10 centimeter SEMS were recommended for US hepaticogastrostomy, while 6 centimeter SEMS for US choledochoduodenostomy, and 6 French cystotomy should be used for fistula creation. I will skip this. This already we have discussed. So to conclude, US biliary drainage is an emerging technique with a demonstrated safety profile. It is increasingly used as a better alternative for PTBD after failed ERCP. There are no RCTs to support the best strategy for US biliary drainage, and I believe the best approach should be decided on a case-to-case basis according to the patient's anatomy and condition. And in the near future, there might be an important role for US biliary drainage as a primary biliary draining technique. Thank you.
Thank you, Dr. Sandip, for extensive review of US biliary drug drainage. So we have actually multiple questions for both the speakers. First, we'll ask for Rana sir, please. Whenever we think about pancreatic duct drainage, sir, in contrast to the biliary, because the duct is small, so usually in biliary we aspirate bile, and we can inject saline such that the bile duct can be distended and can come closer to the duodenal wall for puncture. So can the same mechanism be used for pancreatic duct drainage, because ERCP we are not able to get the wire across? So any role for that? You're mute, sir.
Yeah, that's a good question, but unfortunately, pancreatic duct is a stiff structure, so it will not get dilated with whatever contrast you inject. But the only thing which you have to keep in mind is that you should prime your needle with contrast, so that you don't inject air inside the duct. Otherwise, it will be hell of a business to do that procedure. So prime your needle with contrast, inject contrast, obtain a pancreatogram, and then try to take the guide wire across. Only thing is that you should ensure that the duct is sufficiently dilated, especially if you are a beginner in these procedures, because putting a stent in a 5 mm or a 6 mm pancreatic duct is very, very difficult.
Yeah. Any techniques, sir? Like usually the guide wire sometimes turns towards the tail of pancreas. So any maneuvering technique or the direction of the scope so that we can get the wire towards the papilla. So
when you should actually quite liberally use the fluoroscopy where you are doing this procedure, and especially making a puncture, because once you have decided to make a puncture, then it's a no return step. So you should have your scope facing towards the papilla, right bang in the middle of the stomach, and your needle should be almost, I would say, a little parallel to the duct. That is not possible, but whatever angle you are having is, the needle should also be facing puncturing towards the papilla, so that you don't have much difficulty in pushing the guide wire down towards the papilla. So these are small steps, but doing it is different than telling. It's quite difficult, these procedures, and especially many times even we have faced the problem that the wire get sheared off, because there is not much space for the wire to take a turn. So the duct is 5-6 mm, your needle bevel is 3-4 mm, so the wire has to make a turn and get down. So even in the best of the hands, the wire will get sheared off, and then you will have to again go back and restart.
yeah. So one more question, sir. Like you have already answered this. Like for 5 mm duct, we use the 19 gauge needle. Suppose in a disconnected pancreatic duct syndrome where the duct is not dilated, so any like 22G needle, like whenever we are puncturing, so like suppose double puncture, or how do you get the position, accurate positioning for the puncture of the main pancreatic duct?
I would actually not recommend EUS PDD if the duct is not dilated, because it's very, very tough. Even the best persons will have a difficulty in using a 22 gauge needle and using a 0.018 or a 0.021. You would have used those wires for minor papilla stenting. Putting a stent on those wires is very, very difficult, even in a transpapillary route. So doing it in a PDD where you have stiff pancreas in between, you have a very abnormal angles of the scope with the duct. So I would say the best persons will also succeed only 50% times using a 22 gauge needle. But fortunately, in clinical practice, you would not require to do an EUS PDD in such category of patients where the duct is not dilated. It usually is not required. Even like so far, you would have done about 30 EUS PDDs. So most of the time, I would say the ducts were dilated. I would remember only one patient where we have used a 22 gauge needle, but then that patient, it was very, very tough.
Thank you, sir. So one more question is like the severe complications after EUS pancreatic drainage. So like, is there any difference in the management from the regular? So most likely, I think the question is meant for perforation bleeding, I think so.
Yeah, I think it's a very, very important question. The only thing is that if you have a complication in EUS PDD, you can only do one thing, that is pray. Because what happens is you have made puncture at two places. One is a pancreatic duct and one is at stomach. So closing a stomach puncture is not difficult. It's a small 6 French cystotome which are called a burn. So even a conventional hemoclip, you can close that puncture. But the problem is the pancreatic duct puncture, there is no way you can retrieve that situation, because transpapillary stenting is not possible. Making a second attempt of EUS PDD with a hole in pancreatic duct, you require a lot of heart to do that. It's very, very tough. So I think in those situations, pancreatitis will develop. But fortunately, if you have done in chronic pancreatitis, I think it will be a self-limiting pain for 1 or 2 days, a small fluid collection, and usually it will resolve. The life-threatening complication in EUS PDD is bleeding, which usually happens. What we have seen is that if you have attempted a transduodenal puncture, and in a transduodenal puncture, sometimes you can puncture an artery and then there can be a torrential bleed, which can be immediate or delayed, and you may require a DSA. But otherwise, life-threatening complications are fortunately less, especially if you have chosen your patients well. If you are attempting a PDD in a patient who has got a normal pancreas, especially a disconnected duct, then one has to be very, very careful for severe life-threatening pancreatitis, which may happen.
Thank you, sir. Another question is, what is the comparison data on plastic versus metal stents in EUS pancreatic drainage?
Metallic stents, there are very few studies. Most of them are case reports. So there is no study which has looked at the efficacy of metallic and plastic, and the dedicated stents which have been placed are 8 stents, which are still not available with us and even at many centers. So at present, I don't have any personal experience with metallic stents. What we have placed is plastic stents only. But then I think we are gradually going to have a dedicated metallic stents for pancreatic duct drainage also.
Thank you, sir. One last question for you. Like, what is the frequency of stent exchanges in US pancreatic drainage?
Yeah, I think it's a very, very important question. The only thing is that the studies are very limited. There is no consensus. So each center follows their own guidelines. What we do is, after placing one stent, in the first session, we are not aggressive. We'll attempt placing a 5 French or at max a 7 French stent. And after a month, we'll call back the patient once this tract has matured. We'll first attempt to cannulate alongside the stent. And if we are able to get a wire across, then we remove the stent and dilate the tract and push a 7 French or a 10 French stent. Once we are able to get a 10 French stent, then the tract is mature. Then we do a stent exchange at 3 months and then yearly or on demand. That's what we follow.
Thank you, sir. Dr. Sandip, first question for you, like, how do you choose whether to go for ERCP or EUS biliary drainage? And in what cases you suggest that it should be PTBD alone and not the endoscopist?
So choice between ERCP and US biliary drainage is if there is no obstruction to the D1 or D2, or the first choice is always to attempt ERCP, and if the papilla is accessible. Suppose the papilla is deformed and it is impossible to cannulate the papilla, then only we think of US biliary drainage. So PTBD only if I fail in US biliary drainage, then only we ask for PTBD. Otherwise, we go ahead in the same session, which just change our scope and attempt a US biliary drainage.
Yeah. Or else I think only the right lobe, like whenever it is preferentially dilated, I think so.
Yeah. So if the left lobe, yeah, of course, we cannot do a right lobe hepaticogastrostomy. Only if the left lobe is dilated, then only we can do.
Okay. So which type of SEMS will be better for EUS hepaticogastrostomy? Should it be fully covered or it should be a partly covered metallic stent?
So usually we deploy this geobore stent, which is partially covered. The intrahepatic portion is uncovered and the stomach portion is usually covered. But I have seen people deploying fully covered tubular stents also. That also I have heard that it doesn't cause anything. Cholangitis does not happen. But theoretically, yes, still cholangitis can happen if the side branches are blocked. So it's usually the partially covered geobore stent is the ideal one. And it should be a long stent, nowadays 10 centimeter long stent.
Yeah, that comes to the next question. Like during the hepaticogastrostomy, like what should be the length of SEMS within the stomach to prevent migration? So because majority of the time migration can happen. So what will be the length of the stent that should be remained within the stomach?
3 to 4 centimeter usually we keep in the stomach so that migration does not happen. There is no particular measure. It's by idea, like sufficient length should be there in the stomach. It is usually more than 3 centimeter. It should be. I usually put around more than 3 centimeter. 3 to 4 centimeter should be.
I think it is 3 centimeter in the liver, 3 centimeter in the stomach, so that the migration will not happen and biliary peritonitis may not happen. Yes. Thank you, Sandip. I think one last question: is it safer with equal efficacy a cholecystoduodenostomy or choledochoduodenostomy?
Cholecystoduodenostomy
from the gallbladder to duodenum or choledochoduodenostomy. So which is safer?
I think choledochoduodenostomy will be safer, easier to do rather than, because cholecysto means, I think the question he meant to put in the gallbladder, we'll do it from the antrum if we do a US guided gallbladder drainage. Otherwise, choledochoduodenostomy will be always safer and the first option because it is a easier procedure in comparison to a hepaticogastrostomy. But the literature says that the complication rates might be more with choledochoduodenostomy because of bile reflux of food contents and cholangitis and all. It's more in patients who have undergone choledochoduodenostomy than hepaticogastrostomy.
Thank you, Dr. Sandip. Thank you, Rana sir. I think that was an excellent session. So we thank both of you. I think now I call upon Mr. Atavdeep for a vote of thanks, please.
Thank you, sir, and Dr. Rana. Thank you, Dr. Sandip Pal. Thank you, Dr. Avinash. Thank you. Thanks for the wonderful talk. We had attendees all across South Asia and Middle East, and we also intend to, put this session on various platforms which are free for access, and more people can basically see and learn. That's the intent. So thank you, sirs, and for the audience who's connected, stay safe. Please be at home if it's not required, and goodbye and good night to everyone. Thank you.
Yeah.
Good night.
Thank you. Bye. Good night. Good
Thank
night.
you. Bye.